lack of certainty as to the significance of occlusal factors in implant success. We don't know exactly all things. And so we can stay on common sense clinical thoughts to guide the clinical application. General principles of this common sense. If you look this panoramic X-ray, in this case, the patient made consultation for in comfort and muscle problem. Everything is wrong in this case. If you look the last molar on the left side, probably there is a very strong posterior interference. If you look the wear process of the anterior teeth, probably bruxism and flat guidance, and possible very asymmetrical guidance between the right canine here and the left canine. Probably, I don't know because I have not the clinical view. Excessive curvus P on the left side, very excessive. And flat and reversed occlusal plane in the left side. That means asymmetrical function of mastication, for example, and on the movement. Wrong axis for this implant on the right side. Why wrong axis? Because the direction of the force is inclining majorly, like also the direction of the muscles. It is not the only reason of the direction of the force, but everything is wrong. It is not a problem of number of implants. It is not a problem to discuss the contact between teeth and implant. Is 10 micron or not? It is not. In this case, the basic rules for occlusal reconstructions are forgotten. So we have first to think about basic rules. Of course, there are mechanical risks with implant because they are not periodontal ligament. And the risk frequently encountered are fractures. Fractures of cosmetic, of prosthetic screw, of pillar screw, of armatures, and sometimes also fractures of the implant itself, like here. We have also sometimes a risk, a biological risk. But we have to discuss today on the mechanical risk. Sometimes the occlusal overload is stronger than the resistance of the implant itself. And you can have something which is difficult to diagnose, like a break here on this implant. Screw loosening were reported with the highest technical complications, around 10% in the 5 years. So it is very common complication. And those complications support the argument for a carefully designed occlusal sham. and a rigorous arm maintenance program. We cannot create a periodontal ligament. So we have to pay attention to the position of the implant concerning the axial forces, the direction of the force. Pay attention to occlusal morphology, guidance concept, and behavior of the patient. It is the objective of this presentation. The general principle frequently presented are multiple contact distribution, maximal implant length, optimized bone resistance, and splinting of adjacent implants may be considered to reduce potential morbidity. As a general principle, working side guidance should disclude contralateral non-working side contact. The discussion is between the working side, canine guidance or group function. This general principle. Okay, bite force. You know that in lateral view, the mandible is like a class 3 lever. That means that the force is in the middle here between the center of rotation and the resistance here. More you are close to the force here, more loading here is. Here and is less loading. Very simple, we know this very well. So direction of the force are not perpendicular to the occlusal plane. They keep in mind, are not perpendicular to the occlusal plane. But the bite force are not the same if you have teeth, if you have molar, posterior teeth, for example, or if you have knots. The less terminal tooth is posterior, the less the bite force is important. When we have teeth here or here, you can clench very strongly. When less you have teeth, like this, less you can clench. You cannot apply strong forces against nothing. You need opposition. You cannot have forces without in front of nothing. About forces, we have to discuss 5 minutes on bruxism. Classically, you can read bruxism as a risk factors for implant. And so, for some authors, bruxism is a contraindication for implants. But the number one of the bruxism in the world, Gilles Lavigne, said the evidence implicating bruxism involvement in implant failure is weak. And for some authors, other authors, implants should be considered as negatively affected by bruxism. So, what we have to think about this? We have first think that in many papers concerning this topic, nothing was said concerning the quality of occlusion. In front of a bruxer, we need a very high quality of occlusion first, specifically stabilizing function, quality of ICP, and guiding function. You remember the trilogy of the occlusal functions: stabilizing, décalage, centering, le centrage, guiding, the guidance, le guidage. Comparing natural teeth and implants, centering function are the same, no difference. But concerning stabilizing function, there are something to discuss, and concerning guiding function, there are something to discuss. Okay, now we have first taken account the quality of occlusion. The second point, it is what about bruxism care? We cannot do anything to decrease bruxism? Of course we can, but nobody talk about this. So bruxism for me is not a contraindication for implant. It is indication for high quality of care for the patient. Concerning the process, another point is the ratio crown implant. More the crown is height compared to the bone part of the implant here, more the crown is height, more there are risk for horizontal forces. So we have to avoid a bad ratio, and sometimes there's an indication for graft, bone graft. The crown ratio, crown to implant, CI, is recommended 1:1. More 1:1 becomes biomechanically unfavorable. This one is 1:1, a good ratio. This one is 3:1, 3. 3:1. That is a bad ratio. So it is a risk. For the general principle, we have some information. We discussed the bite forces, we discussed the crown to implant ratio, and what about the occlusal morphology? The general principle in implant, it is very classical to say, we have to reduce the occlusal morphology. Like here. Compare the width of the crown here and the dimension here. It is around 50%. Where the patient go to chew? They go to chew on the more efficient area, on the right side, probably. And it is not a good balance of the system if there are unilateral chewing area. We have to think about this for optimization of the function of the masticatory system. You can reduce the morphology from different type of reduction. You can reduce global morphology, and the occlusal table is reduced here, or reduce only the peripheral part. If you look here, the dimension between the cusp here, the same here. but the peripheric area of the teeth are disappeared. So it is interesting to discuss what is the occlusal table, what is the occlusal face. Concerning the contact, if you have opposing contact on a buccal cusp and on the lingual part, the direction of the force is along the red arrow. So it is not depending of the dimension of the crown. It is depending of the opposition of contact. From this point of view, you can have a large occlusal table because the direction of the force is the same along the long axis of the implant. But in this situation, we consider the high CP position and clenching in ICP position. But during mastication, these things are not the same. During mastication, we have forces, the mandibular teeth is going laterally and coming back like this in a mastication cycle, and the pressure are on lateral parts of the maxillary teeth. And if the crown is very large, like this, you have forces with an important moment of force, clearly more important than here. So from mastication, it is interesting to reduce the occlusal morphology. And therefore, it makes sense to reduce the mesiodistal, note the mesiodistal, sorry, the buccolingual width of the occlusal table. Occlusal table or occlusal face. That is a problem here, because it is different, occlusal face and occlusal table. Come back to your first years of education in dentistry. You have here the more large point of the dimension of the teeth, and it is definition of occlusal face. When you are when you look the teeth from the up situation, you look the occlusal face, peripheric line here. Into the occlusal face, between the cusp, you have the occlusal table. Occlusal table is defined by the crest line, periphery crest line here. It is the occlusal table here. And in fact, the first thing we have to reduce occlusal faces, but not to reduce occlusal table. So you don't really decrease the capacity of stabilizing function, and you not decrease the capacity of mastication if you don't reduce the occlusal table. Reduce occlusal face, yes. Reduce occlusal table, no. Maintain the occlusal table. That is an interesting way to optimize functions. With reduction of moment of force on the teeth. You can don't reduce the dimension of the occlusal table, but reduce occlusal face. And align implant along supporting cusp, like this. In the fossa here, and in the fossa here. Okay, so in this case, this one is an implant. In this case, there are no reduction of the occlusal face. So it is a little bit a risk. Here, the reduction of the occlusal face that is important, but the reduction, that they are not reduction on the occlusal table. So it is an interesting way to guide the technician of lab to give to him this type of instructions. This single implant here. It is the same here. A little reduction of the occlusal table. Low reduction or no reduction of occlusal table, but reduction of occlusal face. In this case, we can have we can start the discussion of the quality of occlusal contact. You can see here on the single implant contact, simultaneous contact, identically with the contact on natural teeth. And it is important to discuss this point. We go on this topic later. We have to avoid off-axis forces. Okay. Everybody is, all the authors are in agreement with this principle. Avoid off-axis forces. But what is the direction of the force? And that is not, this question is not frequently on the table. Loading and axis inclination is clear. When you have forces on the peripheral part of the crown, the direction of the force is like this, with an important moment of force. But when you look some X-ray, for example, you can have some questioning concerning the direction of the implant. For some authors, like Gross, for example, we present a very interesting book, Prosthetic Dentistry, Science and Art of Occlusion in Oral and Oral Rehabilitation. It's a very, very interesting book with a big chapter concerning occlusion and implant. And he said, axial implant inclination at right angles to the occlusal plane when possible. It is for him a current product. Okay. I agree with a little modification to the occlusal plane, no. To the occlusal table of each teeth. Why? Because occlusal plane is a myth. It is not a plane, it is a curve. Name it curve or speed. That means each occlusal table has different inclination. And when you see these pictures, or these pictures, you can imagine that the direction of the implant is not like the direction of the natural teeth. For example, the natural teeth was probably like this, with this direction. Not with this direction. What is the direction of the loading? You have only to see, to observe the natural teeth. Natural teeth are majorly inclined, not vertical, majorly inclined, with different inclination. This one is more inclined, this one is less inclined, and the result is a curve of Spey. This simple observation, with this simple observation, you know the direction of the force. Because nature takes the best way to absorb vertically the force. So we know very well the direction of the force. And it is not vertical. Sometimes you can see implant like this, in this direction, simply because there is an error during the clinical phase. Imagine here the patient, you have to put an implant here, okay, and you have to put the implant in the direction of the previous direction of the natural teeth. It's a good idea. But when the patient opened mouth, and when you put the handpiece into the mouth, if you don't correct the inclination of the handpiece, you put the implant like this, in the wrong direction. It is a very, very classical fault. Clinical error. We need surgical guide to control the implant axis. We say at the start point that the element that we can modify, change is the direction of the implant. We cannot create a periodontal ligament. So pay a very good attention to the implant axis. Direction of the force is like the position of the teeth, natural teeth. The curve of Spey is a natural phenomenon which is a consequence of the inclination of the teeth, variable inclination. Each occlusal table are different inclination for each teeth. And remember Aristotle's principle, nature does nothing in vain. It's not by random, it is because there are biomechanical rules behind it. And the biomechanical rule is very simple. If you observe the position of the lower incisors, when you are closing the mouth, turning around the condyle, the direction of the force is tangent to the closing cycle, 90 degrees here. It is not vertical. Is inclined. And it is the same for the molar, but the inclination is different. like this. And it is the direction of the teeth. To optimize the verticalization of the loads along the long axis of the teeth. The same for the implant. This topic is, for me, it's very interesting, and we publish a paper, numerous papers on this topic, and you can have a paper on the curve of Spey and a paper specifically concerning control implant axis inclination, measure inclination of the implant, in 2 papers here, and you can scan this QR code to obtain the PDF of the paper. It is the same concerning the frontal view. Implants are not vertical because the direction of the force are not vertical. It is a problem for connection of implants, so we have to make some compromise. And when you have a connected implant in a full arch, for example, the direction is a resultant of all the system. But for a single implant, you have to incline the implant along the direction of the force, not vertical. Optimization of the direction of the implant is an important point. Okay, for this, so we draw some clinical common sense to guide the position of the implant and the morphology of the crown. Now we go into detail to the occlusal adjustment in ICP. In ICP, the general law is to when you put a crown on a natural teeth, you must have contact on ICP position in the same time simultaneously with the other teeth. It is integration of the crown into the ICP, natural ICP of the patient. If you have to participate to the stabilizing occlusal function. If the crown is too high, it is a supra-occlusion, and we cannot have contact on the other teeth. And the patient say, oh, there's something wrong here. They're too sick. Or you can have a crown without contact, infra-occlusion. And so if the crown is no contact, the patient is okay, no problem for me, perfect, but no participation on the general contact of the arch, and so you are loading the other teeth. First problem. And the other problem, you have supra-eruption of the teeth, because it is a natural phenomena that we have with natural teeth. What's happened with crown on implant? When you create another occlusion, supra-occlusion, over-occlusion, that means the crown is too high, you obtain bone loss. You can obtain, not in all studies, because nothing is simple in biology. And from this paper from Miyata and others, the results propose that the more the premature contact on the implant prosthesis, the more the crestal bone loss. So we everybody's are okay to avoid over-occlusion. No problem. If you look more globally, the mechanical risk factor for implant, you can afford for type of risk. And this draw is from German Gallucci in Boston, I think so. You have the magnitude of the force in relation with the occlusal forces, location of the implant, and bruxes. You have the distribution of the contact and of the implant and the situation of the implant and occlusal design. You have the prior functions concerning the duration of the loading and duration and the direction of the loading. It is implant position, off-axis implants, cantilever, or occlusal interference. And it is interesting to separate all the things. Concerning over-occlusion, it is sometimes difficult to interpret the results and to analyze the methodology of the research. When you create an over-occlusion here on a model, on animal models here, for example, you create an over-occlusion. You are loading the implant, okay, but frequently you create an avoidance reflex. So when you create a too thick crown, that doesn't mean that the animal or the subject clench on it. The normal reflex is to avoid it because I'm not stable. So it is not so easy to interpret the result of some research. With the extra thickness, the natural reflex is avoidance. So this is not so easy to interpret, and again, this reflection, this observation can increase capacity of analyze research. For some people, in dentition restored with teeth and implant, initial contact in intercuspal contact position, ICP, must occur only on natural teeth. No charge on implant. And if you follow this principle, you obtain this out of occlusion. Not from 10 microns. 2 millimeters infraocclusion. That is a risk. That is a problem. It is a classical law now from Misch, 1993, who explained that to adjust a single crown with the implant, specifically in ICP. When the patient is in contact, light or medium intensity, you come to ICP with light or medium intensity. You have, following Misch, you must have only contact on the natural teeth. Contact here, but no contact on the implant. It is a crown with implants. And with a clearance, it is a space, free space here, clearance of 30 microns. And after, when the patient closes strongly in ICP, you have intrusion, natural intrusion of the natural teeth, because of viscoelasticity of the natural teeth, and you have contact on the crown, on the implant. So this clearance of 30 microns aims to compensate for the different biomechanics of the tooth and the implant. This rules is a general principle which is presented now in all parts of the world. And you can see it in many books and in many presentations and in many lectures. Okay. But there are different situations. And for example, in this paper from Willow and others in 2008, they tried to analyze different situations. To say, yeah, here we have to make some contact, direct. And in this situation, we have to maintain clearance 30 microns. For example, for completely edentulous patient, you make a full fixed prosthesis on implant, you can have a clearance of 30 microns. It is impossible. So here, in this situation, you need to contact in ICP on all the teeth. That is the first difference. Like this. It is a full dental arch on implant, and all the teeth must be in contact. There are no differential occlusal adjustment. In this situation, contact, full arch simultaneous contacts. So we have, from now, at this moment, we have two different situations, full arch and a simple implant. For some people, they are put in the same box, the problem of the contact and the problem of the height of cusp. The height of cusp is different because we can have contact, simultaneous contact, or clearance with cusp or without cusp. So we have to distinguish the bone. If you come back to the table of Rilot, you go to partially edentulous patient, single tooth implant. The rule for Rilot is clearance between occlusal clearance 30 microns between the crown and implant and antagonist. But it depends what is the antagonist. If the antagonist is a natural teeth, like here, the natural teeth is able to absorb the difference of a viscoelasticity reaction. So when you have a single implant against a natural teeth, you have to organize simultaneous contact on all the dental arch without the clearance of 30 microns. No interest. And if you maintain a clearance of 30 microns, the natural teeth go to present a supra-eruption, natural supra-eruption. So, and you cannot control all the occlusal parameters if the teeth migrate. If you have a migration of the teeth, natural teeth, you can have after some interference and something like this. So stabilize the dental arch and organize simultaneous contacts on all the dental arch, like here. Or like here. You have a crown on implant here. This is a situation where you have crowns on the natural teeth and a crown here on implant. And you have simultaneous contact. It is integration of the prosthetic system into the natural ICP of the patient, with the crown, with the implant or not. And you can see here the reduction of the occlusal face without reduction on the occlusal table. The occlusal table is like this. Okay, and you can see we publish a paper in French on the occlusal adjustment on a prosthetic crown and implant, and you can have, with a QR code, you can have the PDF of the paper. You can have a screen print if you want. We saw an example on the posterior teeth. Here it is an example of anterior teeth. It's the same rule. Natural antagonist, you can hear, natural antagonist, and participation of ICP without difference, without clearance, same contact between natural teeth and teeth on the implant. Because the natural antagonist is able to absorb the difference of viscoelasticity. No problem for me. That means we have to different situations to observe different situations. Full arch, simultaneous contact, single implant, without natural antagonist, with natural antagonist, simultaneous contact. Even in this type example of anterior unit. Okay, another situation is distal implant. No natural teeth behind here. In the distal part of the arch. How to adjust the ICP. With natural teeth, we say, okay, we adjust simultaneous contact with antagonist natural teeth. No problem. But it is not which is described in the literature frequently. For widow, for example, they say, oh, we have to make a clearance between light ICP and strong ICP. What's happened if you do something like this? And here it is not 30 microns. But you can write in a paper, in scientific paper, you can write, you have to maintain a clearance of 30 microns. And the reality of the clinic is put infraocclusion of 1 millimeter or 2 millimeters. So what has happened for this case? When you have infraocclusion on posterior teeth here, and when the patient active strongly closing muscles, you have a rotation around this point. This rotation creates compression of the TMG. And the resilience of the TMG is 6 times more important than the resilience of the periodontum. So, to put the posterior teeth in infraocclusion expose TMG to a risk of overloading. If you do something like this on a distal teeth, implant or not implant is the same. You active the clothing muscles, and the risk is for the TMG. You have direct compression of the TMG. So, in this situation of distal implant, with unit or small bridge, the rule for me is simultaneous contact on the dental arch, even if you are implant antagonist. It is natural, it is an implant crown on the molar, simultaneous contact in ICP. The same for these 2 crowns on implant, terminal crowns, distal crowns. It is the same for bilateral distal implant, simultaneous contact on all dental arch. And I would like to underline, it is this principle that I presented now is the same if the antagonist is implant, because the resilience of the joint is so important that they can absorb directly the difference. So in this case, simultaneous contact on dental arch. That means in the graph of Rilo, there are some different lines of indication of simultaneous contact. In fact, really, the question of the integration in the ICP is only when you have single implants in antagonist without natural teeth on the anterior part and the posterior part. If you have natural teeth here, you can, with antagonist implants, you can think about a little difference of adjustment between natural teeth and implant, because there are a difference of viscoelasticity to absorb the force. And it is the only situation where a clearance of 30 microns could be left between the occlusal face of the implant. That reduce considerably the problematic of the occlusal adjustment of implants in ICP. In all other cases, you have to organize simultaneous contact on the dental arch. Another problem concerning the adjustment of ICP is cantilever. Because the distal extension, cantilever is a risk factor, a strong risk factor. And the classic rule is no occlusal contact on the extensions. But it's not really clever, because if you have infraocclusion of cantilever here, first you have no stabilization of eventually a natural antagonist teeth, and you have TMG loading. Okay. So it is not very efficient. But if you don't make, if you adjust to participate in simultaneous contact here, what is the risk? The risk when the patient clothed in ICP, there are not a lot of force. Because the force is, there is a repetition, there is all the force is distributed on all the teeth. That means there are not a lot of forces here. And the movement, posterior movement, eventually is compensated by the opposition here. The question is to have a good junction here, a thick junction, to have a good resistance of the material. The problem is not the clenching situation in ICP. The problem is mastication. If you chew something a little bit hard on the extension, there is big risk. That is a risk here, because there are a lot of charge here and no stabilization at this level. So the real problem is the mastication of the extension. And so from my point of view, we have to organize with an extension, to organize simultaneous contact in ICP and all the dental arch to stabilize the antagonist, to protect temporomandibular joints, and advise chewing on the other side. The patient has to chew when it is something little bit hard on the other side. You must avoid to chew something hard and this on the left side. How to adjust ICP and bilateral cantilever? When you have bilateral cantilever, you cannot say to the patient, oh, you have to chew on the anterior teeth. So he cannot chew because there are risks. He must chewing only soft food. It is a price to pay to this type of situation. If you don't want to pay to organize this situation, you have to put an implant here. But not put extension without contact. If you have not contact, there's a risk for TMG, is a risk for antagonist, for the teeth, which are here, natural teeth. Concerning the determinant of occlusal success, we was discussing from 15 minutes, perhaps, concerning the difference between a light ICP and a strong ICP with a clearance of 30 microns or not. But the success is not here. The key of success are not here. The key of success is first integration into a global treatment planning of your implant project. Global view of the treatment. Think to what are the teeth, think to functions. The second point is choice of reference position. Clear, ICP or centric relation, for example. The third point is the choice of vertical dimension. The other point is the organization of the occlusal plane, the curve, occlusal curve. The aesthetic aspect, the position of the implants, more or less buccal, more or less inclined in front of the support clasp antagonist, the guidance concept for the next chapter of this presentation, and the last point is only ICP contact. It is not so important concerning the occlusal success, and we discuss it from 30 microns, which is not very so significative. The problem of occlusal adjustment of passive light intensity or active contact, strong intensity in ICP is only like an icing on the cake. So keep in your mind this integration in the ICP of the patient, participation in the ICP to distribute the force on the full arch. That is the main objective. Beforehand, there are other much more important parameters to take into account to ensure the success of the treatment. And don't forget it. First, implant is like a dental ankylosis. And when you observe some natural teeth with ankylosed process, it is rare, very not frequent to have a periodontal problem on this teeth. It is just a clinical feeling that I have. I don't make research on this, but I feel periodontal problems are not very frequent in ankylosed tooth. It's the same for implant. But implants are not so fragile. The natural teeth beside the implant are not so strong. If you look this patient, infraocclusion of 2 crown here on implant, distal implant. The contact on ICP is only on natural teeth. No contact here. And the consequence is there is no contact on posterior teeth. The consequence is a fracture of the crown here. It is the reason for the consultation. Recent coronal fracture here. And mobility and inferior pocket here. Look at the radio. Implant, okay? Look at here. If you unload the implant, you load the adjacent teeth. The molar, the role of the molar is to protect your teeth, which are weaker. It is the main reason to participate to the ICP. The major risk is for the adjacent teeth, adjacent natural teeth. Okay, now we can open another chapter, specific chapter concerning mandibular all in four, like this, for example. And it is not to discuss concerning the occlusal adjustment in ICP, because in a full arch, we have to obtain simultaneous contact in ICP. Okay, the discussion concerning the implant direction and the force. And if you look this type of cases, the direction of resistance of the implant system is like this. But the direction of the force is like this. Remember, perpendicular to the condyle. It is a tangent law. So there is a problem. If you put an anterior implant, you have to align the direction of the implant to the tangent of the closing cycle. That means perpendicular 90 degrees here between the implant and the closing radius, which is here. Go to the condyle. Because the closing movement is a cycle around the condyle, and the direction of the force is like this. Is like this. That is a good direction for anterior implant. And we have to try for a full implant arch to organize the resultant of resistance perpendicular to this direction, like this. Concerning the classical all-in-4, which is of this concept, where the distal implant is inclined in distal direction, and the mesial implant is a little bit more vertical, you can propose another schema of organization of the implant with the anterior implant very inclined on buccal and the posterior implant very inclined on distal to obtain a resultant of resistance like this, which superpose with the direction of the force. For example, here, which need a surgical guide. We need a surgical guide, and the direction of the implant, you can imagine the direction of the implant here with these pictures. And here is the implant. And it is not really a problem from prosthetic procedures, but probably more interesting from mechanic point of view. I have not document to support this concept by research for the moment, but it is for me an interesting way, and we have to think about it. And the last point that we have to open is a guidance concept. We will have three parts of the guidance concept: classical principles, the discussion between canine function and group function, and organizational full arch. Classically, we know that tipping forces, that means horizontal forces on implants, are harmful. They can arise as a result of cusp inclination, angulation, during lateral excursion in the mandible. And it is, the conclusion of this is frequently no cusp. And canine on implant is a real critical point. A single implant on the maxillary canine is a critical point of this topic. And we will discuss it at the end of this chapter. Classical principle. It was illustrated by, in the paper from Rillo. If you have natural canine here, relation, you can have a canine function. And no participation in the movement of the implant system. That is first rule. Second rule, if implants are concerned by the guidance, like here, you have to organize a group function. Simultaneous contact between the canine, the premolar, the third, and the molar. It is a large group function. That is guidelines, classical guidelines for occlusion strategy concerning the guidance. Reducing shear forces means no anterior guidance. And it is general principle. And when you look at the application of the general principle in a daily practice, you can observe this: no cusp. No cusp, no risk. And it is supported by science, because when you decrease the inclination of the cusp, you decrease the force. But that doesn't mean that you can avoid all problems on fractures or chipping if you have not cusp. Overloads can occur even on occlusal flat teeth, specifically when you have not guidance. Because when you have not really guidance, it's very difficult to adjust the occlusion in a function, in good function, in all the movement of the patient. Very difficult. It's more easy with the canine guidance. Okay. And so the general principle with implant with crown on implant is to avoid localized stress concentration. For example, by canine guidance. When you have a canine guidance, you concentrate the load, the stress, mechanical stress on the canine, because there are contact only on the canine, no distribution of the force. And we are afraid by this. And the conclusion is you have to restore with a group function, and even if it is a full arch. For full arch, where the full arch is reconstructed, balanced articulation is preferred. I completely disagree with this, because it is very difficult to make it, to adjust it, to control it. So a big risk for chipping. Look at this case. Full arch, many implants, no cusp. Everything is flat, but still chipping. Is it surprising? Absolutely not. No guidance, more chipping. For two reasons. It is difficult to adjust, and also because there are intense muscular activity. If you are in a group function like this, it is a lateral movement on the right side. You have contact here, here, here. This is a group function. When the patient is in group function, he can clench the teeth. You can clench, activate the closing muscle strongly in lateral position because you have a support. And so you can see the strong electronic on EMG, intense activity of closing muscles in group function. If you go on lateral, if you have a lateral guidance of the canine, only the canine is in contact in lateral movement on the right side here. You cannot activate the muscles. You cannot because it is unstable. And you have proprioception of the canine, and we saw this point in the first part of this presentation. Canine function is an economical way to pilot the mandibular movement. Anterior guidance is a load brake. Group function is physiological. Natural group function is very frequent and it is physiological. It is a natural reality. It is interesting for mastication. But group function generates loads and frictions, risky for the artificial teeth. Not really for the natural. They are wearing, but it is not really a strong problem. But for artificial teeth, frictions are a problem. Group function is difficult to perfectly adjust and requiring sophisticated simulation in lab. You need simulation of the lateral movement with analogic articulator or digital system, whatever. You need it to have this adjustment. So more perfect as possible. So group function is not an easy way from therapeutical concept. Natural group function, no problem. From therapeutical concept, for me, group function is difficult. And indication for group function from therapeutical concept is only in case of weakness of the canine. A canine function is a hand loading tool. Canine function is sometimes physiologic, naturally, but frequently it is a concept, theoretical concept, to simplify the process, the procedures, and to simplify the movement of the mandible. The guidance protects the teeth by reducing the loads. It is simple to realize, and it makes the treatment more reliable. The question is, it is a loading risk for the canine, yes or no? First, canine is a hand loading tool. We have many papers which show that in presence of the canine guidance, we have low charge on the teeth. Little bit more charge on the canine, low charge on the globally on the teeth. It is another research on this topic, on implant. One of the problems for the canine guidance on implant is the direction of the implant, the inclination of the implant. The inclination of the implant, maxillary implant, is very unfavorable because it's like this, and the direction of the force is like this. Another point is that we have a low thickness on the buccal bone table. So inclination and bone table are unfavorable aspects for resisting to the contents linked to a guiding function. That's true. And so, what will be our guideline to choice guidance? If you have a single implant on the anterior part, like this, you have to adjust the contact on the implant in the same direction and the intensity than we have contact on natural teeth, which is beside the implant. So when you do this, you have a double positive effect. The natural teeth beside the implant is like a proprioceptive alert, very sensitive teeth, the anterior teeth. And the implant is a mechanical support for the natural teeth. Because the implants are very resistant, a big quality of resistance when you have a good stimulation of bone. So, same contact, same guidance, and double positive effect. The implant provides mechanical support and the natural tooth provides proprioception. Okay. If it is a single canine, maxillary canine, the general rule is guidance on the single implant should be avoided if alternative guidance is possible. This is from Martin Gross. And when you have a single implant on the canine, my position, it is a personal opinion, we can organize guidance on the canine with simultaneous contact on adjacent teeth. With this, we have a small function, group function. So problem that show with group function, it is a risk for chipping, friction, difficult to adjust. The problem is more important if the group function is large than if the group function is limited. If the group function is limited to 1, 2, or 3 teeth, it is more easy to adjust. And if the anterior teeth are concerned, like the first premolar, for example, there is important proprioceptive capacity on the anterior teeth, and so there are less muscular activity. So when you have a canine, maxillary canine, single implant, you can use a small group function to have the double positive effect. Mechanical support by the implant, proprioception by the natural teeth. And here you can see, look at the contact, guidance, and guidance in the port. And the group function will be less large as possible. It is group function with on the lateral incisors and canine. Of course, you have participation of the implant to the natural ICP of the patient. If you have two connected maxillary implants between a canine and a first premolar, for example, the things could be different, like there. Participation of the ICP, okay? And you can concentrate the guidance on the canine because you have the resistance related to the connection between the two teeth. You have the good resistance of the system. And so the overall loading on the canine is distributed on the two teeth. And so you have the benefits of the reduction of the forces because only one contact in the anterior teeth cannot clench, and mechanical resistance related to the connected tooth. When you have a bridge on some implants on the posterior, on the lateral side, you can have this illustration by this case. The patient came to the office with he lost one implant here. And so we decide to keep this implant, this one, and add two new implants here, and organize a new bridge like this. This one was implanted before, and we keep it, so it is not in a very good situation. And the occlusal morphology is like this. And we decide to organize a guidance here on the distal part of the canine, more anterior possible, but not on the mesial part of the extension, because the moment of force is very important here. So we organize the guidance in this part. Participation of the ICP, simultaneous contact, canine guidance. But the real question is a simple maxillary implant. And sometimes we can organize on a single implant, maxillary single implant, canine function. We made some cases like this without problem for the moment, but I have not scientific evidence to give you about this concept. When you have, I forgot to discuss the situation of an implant on the canine. If you have an implant on the canine against natural teeth, implant, for example, the implant here, we make we use the natural guidance of natural maxillary teeth. So there are not real impact for choice of the guidance if the implant is on the mandibular canine. So the problem of the guidance concerns essentially the maxillary teeth. How to adjust full arch splinting? Simultaneous contact in ICP and canine guidance. Because from research, we know that when you organize a canine guidance, like here, you decrease the forces. With group function, you increase the forces. And there are a lot of paper to support this. The lowest stress value were observed with canine guidance in all conditions, in all structures. Canine guidance is an unloading system, piloting the mandibular movement. And so, with this type of case, we organize a canine guidance on the incisors for protrusive movement, in lateral movement, canine guidance here, and canine guidance here. That doesn't mean strong canine guidance. We saw the first part in the occlusal function, the guiding function must be open, with less inclination as possible. Because we need free movement for the mandible, no locking the system without interior interference. Okay. So we are now at the end of this presentation. I'm happy to be on time. The philosophy, no cusp, no contact, is not my philosophy. I disagree completely, because if you put teeth in a patient, the teeth must play the role of teeth for clenching, grinding, mastication, smiling. So I strongly disagree with the no cusp, no contact attitude. Why? Because I want to have mandibular stability when the patient claws for swallowing, for example. I want to have a residual teeth stability. I don't want to impact the natural teeth besides the implant. I want to protect TMG. I want masticatory efficiency. I want bone stimulation. And you can have a better bone stimulation with a good occlusal functions. Optimization of the occlusal function is a good way for increase probably the success of the treatment. Of course, there are specificities of occlusion and implant. The system being less tolerant, no periodontal degagement. That means that we must be more attentive. You have to pay more attention to the occlusal adjustment. All general criteria for construction are major factors of success. Don't remember the pyramid. For success, the general problems, all different problems must be taken account before to discuss the 30 microns of adjustment. Control of excessive parafunction by patient education. It is necessary in active Braxton. Optimization of the implant axis along the closing force direction. That is the main way to optimize the forces absorption. ICP participation like to the other teeth. Some lighted occlusion for single bonded implant antagonist to implant. It is the only case when you can open the discussion about the light ICP and strong ICP. Canine function is the first choice of short function group as anterior as possible if in case of weak canine. Another point on implant, I recommend to use Brack checker to control the occlusal adjustment. Use Brack checker every one night is recommended to check the reality of contact after 1 week, after 1 month, after 3 months, and 1 year. It is a very simple tool, and you can read the reality of the contact and make some adjustment, little adjustment to avoid, specifically to avoid chipping. Occlusal risk is not zero. With implant, the system being less tolerant, and so the occlusal adjustment must be more precise. That this does not mean that crown on implant must be off of occlusion, which create significant risk for residual teeth, TMG, nutritive function. Remember, occlusion on implant is more demanding than occlusion on natural teeth. So, thank you very much for your attention. I hope to help you in the knowledge of the management of occlusion on dental implants, and perhaps see you next for another topic. Bye-bye.